He's come to us from Cincinnati. Last night he was diverted to Cedar Falls, threatened with a 4-hour drive or a bus ride here, but managed to make it. He'll be presenting over the next 2 days to the neurocritical care group and folks that are interested downstairs. This is kind of an introduction that he's giving to our group. We're so grateful. I think it's really extraordinary that 5-6 months ago I emailed Brandon and I said, "Can you present to our groups on multimodal monitoring?" He said, "Oh yes, I've got 2 days that I can do," and it's very rare that you can have someone that's that generous and that skilled. So we'd like to welcome him, and we're very excited for his presentation. Yes, so immediately following Brandon's presentation here, we're going to have a demonstration of the quad bolt placement with for the residents with Hemodex, and then following that on the first floor, we'll have Dr. Foreman's workshop.
Great. Thank you guys. Appreciate it. Thank you, Patrick. I really, really appreciate it. This is a fun topic for me, and the workshop that I put together previously, it's a great opportunity to be able to share that with you guys for whoever can be here for 2 days of me talking. But it goes through a lot of the stuff that you see in clinical practice and a lot of the stuff that's applicable to what you guys do or will be doing. So I think that's, it's a good opportunity to see sort of the real world messiness and utility of doing what we're talking about now, which is neuromonitoring in clinical practice. So I'm going to try to go through things, relatively quickly because this is an overview. And we'll stick to the 45 minutes, of course, to try to make sure you guys get to your next lectures and cases in time. My disclosures, the pertinent ones here, in particular are, I have provided some marketing consulting and received honoraria from the Natus company. They are the makers of some of the equipment that I do talk about because that's what I use clinically, not an endorsement per se, but that's what we have in our ICU. And research funding from various sources, but nothing necessarily relevant here. All right, so the plan is to discuss just a framework in general of what multimodality neuromonitoring is, like what does that mean? And then we'll talk about what you might need to do that, because it's not a simple thing in terms of sticking something on someone's head and moving on with life. There's a lot that goes into it and a lot that goes into it to make it useful, which is the real key, right? And then we'll talk a little bit about how you actually can look at the data that you're generating when you're monitoring someone's brain in a useful way, and how to approach sort of seeing that data, interpreting it, and communicating it to the ICU staff or to your neurosurgery colleagues when you've got a patient who's actively being monitored. So we got to start with the big question, and I actually didn't know how to answer this for a long time, which is, what is neuromonitoring? And I'll start with the central tenet of what we do in neurocritical care, because that sort of sets the stage for what neuromonitoring is. And that is essentially the identification, prevention, and treatment of secondary brain injuries. And that was outlined in a consensus statement back in 2014. And it really has guided a lot of what our field does, which is you've had a primary injury, and now we want to make sure to prevent secondary injuries. And that's really important because when it comes to clinical neurodeterioration, that happens in about a quarter of all folks with acute brain injuries, whether TBI, stroke, intracerebral hemorrhage. And when that occurs, it increases your mortality by an order of magnitude. So it's very, very serious. But in many patients, we can't detect neurodeterioration. They're comatose. They have a severe injury. And so we have to rely on other markers of secondary injury, and those are extraordinarily common. So 90% of folks have elevations in their intracranial pressure. Nearly 90% have hypoperfusion or low CPP. You'll see some 60% of patients who have seizures or spreading depolarizations, metabolic crisis, all these things are markers of secondary injury. But what really is secondary brain injury? It's not any one of those things. Those are all kind of markers. And there was a study out of the Cambridge group where they looked longitudinally at PET scans in patients with traumatic brain injury. And what was really interesting in that study is that they showed that when you have an acute brain injury, particularly traumatic brain injury, subarachnoid hemorrhage applies here as well, you end up with patchy areas of low blood flow, patch areas of decreased oxygen extraction fraction, and changes in your CMRO2 that are disparate or discordant. So areas of ischemia with areas of hypermetabolism, and they occur in patchy, heterogeneous areas that don't necessarily overlap. And that's a really critical point. I think of this sort of as ARDS of the brain, if you're more of an intensivist, but ultimately the underlying pathophysiology is a mismatch in the ability for the brain to get supply and its demand in using that supply. That's the underlying pathophysiology that leads to infarction or other neuronal cell death and characterizes secondary brain injury. All these other things are really markers, and that's what we're using to try to intuit whether or not this is occurring and ultimately how to treat it. But when you talk about neuromonitoring, it involves several different things. So I'm a knuckle dragging intensivist, so I have to make things really simple. So I think about it in terms of the mechanics, which is pressure and flow, the metabolism of the brain, how it uses oxygen and glucose, and the function of the brain, which in many patients is our neuroexam, right? But in the ICU, in those severe patients, severe brain injured patients in coma, you can't rely on that. And so we often use electrophysiology, such as EEG. But there's a lot of challenges to doing, so to speak, neuromonitoring, right? So one is there's no standards. So what I use in my ICU is different from what you guys use in your ICU, and there's no set number of or type of monitor that's necessary to use. You don't have to use ICP, do you? Or do you? I don't know, right? So there's a lot of challenge there because there's no standards and there's no agreed upon context of use. Do you use it on TBI or do you just use it on sub-Iraq, right? Where I grew up, it was all sub-Iraq, and then I get to Cincinnati, and apparently Ohio drivers are awful, and I see nothing but TBI. So the context of use is also different depending on where you go. Does neuromonitoring or monitoring the brain require invasive monitors? Does it require non-invasive monitors? Can it be just non-invasive, right? So everyone uses different things. If you go to the peds world, they're using nothing but non-invasive, right? Can't really stick a bolt in someone who's got a soft skull. But nonetheless, you know, for a lot of folks, ICP is this kind of mandatory thing. So how do you define it? So I set out to try to answer that to some degree with a Delphi consensus across 35 of my friends and colleagues, mostly across the US. And we ask a lot of questions because this is really sort of uncharted territory to get consensus. And the first thing we said is just, why do you use brain monitoring? What's the point of doing this in the clinical space? Don't we all do this already? And the patients for whom this is useful, of course, as you can imagine, are the folks who are at potential risk for secondary brain injury. Think for your subarachnoid hemorrhage patient who is at risk for delayed cerebral ischemia. And then we ask, well, why? Why do you do it? What's the point? And the thing that really I thought was interesting and pointed that got agreement and consensus was this idea of it guides individualized management. So the point isn't to say, oh, they have secondary brain injury. Cool. It's to say they have secondary brain injury. What does this patient need? And the other thing at the very bottom there that was actually really important, and probably the most important thing in my mind, is it allows you to abstain from or de-escalate your therapies. And that is just as critical as actually adding things on, right? Again, there's tons of variability. So in survey after survey, you know, does my pointer work? It does. ICP is the most common thing that most people use. 95% of centers tend to use this across mostly the US and some centers in Europe. But when you start talking about these other things we think of as brain monitors, like continuous EEG, maybe 60% here in the US, it's more like 20% in Europe. If you start talking about microdialysis or cerebral blood flow, you're talking about less than 5% of centers actually deploy these things to try to get measures of brain metabolism or brain flow. And when we look at, for instance, the track TBI data set, right? This is across big academic centers all doing, you know, kind of cutting edge TBI work. This bar plot shows you per center in the color how many folks are monitored with arterial blood pressure. Should be most, right, in this context. And it's 105 have our real high resolution waveform data for arterial blood pressure. ICP, not quite as many. PRX, which I'll talk about the same if you have ICP. CPP, but then you get into brain tissue oxygen, EEG signals, blood flow signals, right? So these are things that you kind of see variability even within the context of a large observational clinical trial. So how do you define it then? So this was kind of an operationalized framework. I wouldn't say this is a definition. Certainly CMS is not looking at this and saying, well, you're not doing neuromonitoring, although it would be nice if they said you are doing neuromonitoring. And this is sort of what we came up with as part of this consensus criteria. If you're doing neuromonitoring, you really want to know something about mechanics, metabolism, or function. Any one of those or any two of those three would be really helpful. And so at least two brain focus measurements, it doesn't matter if they're non-invasive or invasive. You can use quantitative pupillometry and an ICP monitor, which is great, but you should also have at least one systemic cardiopulmonary measurement. Why? That stuff interacts, right, with our intracranial physiology in really massive ways. Most of the time, we do that. We have arterial blood pressure, or we're doing end-tidal CO2 monitoring. But the key when it comes to this stuff is that you really need to be able to integrate this stuff. Arterial blood pressure is not all that useful for intuiting, for instance, the status of cerebral autoregulation unless you've married it to the ICP. So you've got to integrate it somehow, somewhere, in some kind of platform. It doesn't really matter what it is, but it has to be integrated and time synchronized. So you can see both. You can do analytics on both, whatever you want to do. But more usefully is displaying this stuff together at bedside. So if you can see it and see what happens to your ICP and your blood pressure when you give a bolus of sedation, that's when neuromonitoring becomes really, really useful. And then kind of underscoring the clinical utility of stuff is you really need to have some kind of clinical data, some kind of clinical context, whether those are bedside annotations that your bedside nurse is putting in and saying, hey, I did this at this time, or whether that's using your EMR, just something that integrates to tell you, okay, that's when that bolus of sedation was. So then you can interpret the rest, right? So now you start kind of hanging all this stuff on a better definition of what neuromonitoring is, which is really access to some set of measurements, as we talked about, that are directed toward identifying that secondary brain injury that's part of the central tenet of neurocritical care, and that you use to guide individualized care. So this is an active process. This isn't sitting back and looking at a CT scan in the radiology room. This is actually performing, right? And that's the fun part of doing this. So what's the evidence? Well, there's not a tremendous amount, as you can imagine, but diagnostic studies really aren't subject to the same level of evidence, right? So there was this terrific narrative review from Jeanette Tass that I highly recommend if you have an interest in this, because they cover all of the existing observational or prospective clinical trials that are out there that involve more than one neuromonitoring modality. And there's 43 of these studies, and they kind of put them up here based on the disease process, which you can see over on the side here. I can probably point on the computer more easily. And then the types of modalities that they're looking at. And these are small, but you can see there's multiple different combinations of various things, everything from brain temperature to intracranial pressure to everything, microdialysis, oxygen, EEG, and the whole 9 yards, right? And this Circos plot just highlights the interrelationships between what these studies are putting together. So most use ICP, that's that big red blob, right? But some of the studies use ICP, and then you can see the ribbon goes over to PBTO2, and the size of the ribbon is the number of studies that involve both of those modalities. So there's a high variety. Again, this speaks to the lack of standardization. Nonetheless, there are, some studies out there that describe some form of multimodality monitoring. But again, does it work? And we are limited a little bit in that regard. So in that study, they categorize what kind of studies you're talking about. And the interventional studies where we look at a clinical endpoint were a lot fewer, as you can imagine. There were 9 in total. And of those 9, and we'll talk about some of them, as it turns out, some 82% of those, or I should say 7 of those studies, actually showed clinical benefit to doing some form of neuromonitoring, whatever it meant to that group and to that center. So Maipinder Sikhan is a guy in Canada who's done a lot of this work actually and done it very nicely. And the first, kind of earliest study he had done is he had a service line that did not include any neurocritical care, and they instituted neurocritical care, and it included a combination of ICP and PBTO2 monitoring that he called multimodality monitoring. And the first thing he did was just a historical case control. And they said, well, before we did this and after we did this, how did those patients do? And it wasn't a tremendous number of patients, but enough to make some inferences. And when they did that, they saw a couple of things. So one is they were able to change the mean arterial pressure in relation to what they were seeing. They were able to get better temperature control. They did use more pressor, probably because they were targeting a CPP, right? And they had higher sodium. So they were doing stuff. Again, this is active. And when they did so, there was a signal toward an improvement in outcome. from before to after, where you see the shift in the Grata plots that highlight the fact that it does seem to be making some form of difference. Now, you guys are all familiar with the BOOST study. BOOST 3 is ongoing, of course, but BOOST 2, when it came out, did have a signal toward or trend that was not powered for improvement in outcome as well. You can see the shift in the GOSE and the disability ranking score at 6 months when you used a combination of PBTO2 and ICP targeted therapy. Another study that came out was brain tissue oxygen and subarachnoid hemorrhage. They had this was a retrospective study, but a good number of patients. And they monitored about 2/3 of them with just ICP, but the other 62, they did a boost kind of thing, right? ICP and PBTO2. And again, if you had ICP guided therapy versus ICP and PBTO2, you sort of shifted your plots. And so those are, some compelling pieces of evidence. If you're using neuromonitoring to define your secondary brain injury, there's a group led by Veldeman that used subarachnoid hemorrhage or enrolled subarachnoid hemorrhage patients initially in a retrospective study. And they said, okay, we're going to use our multimodality monitoring and put it together to suggest delayed cerebral ischemia or to enhance that diagnosis. It's not just your TCDs and your clinical exam and a CTA. Now we're going to add microdialysis and PBTO2. So we're going to use that to push our therapies perhaps more aggressively, earlier, or maybe even pull back if it's not consistent with vasospasm. And again, they looked before and after, and there was the same shift, right? Seeing the same kind of data. In cardiac arrest, Sekon et al. Come back to show us in cardiac arrest even, there may be a role for multimodality monitoring. Very similar findings of active use of pressors, increasing your CPP, temperature control, et cetera, and some signal toward perhaps better outcome, although this is a very, very difficult patient population because of the high mortality. So in order to do this, it's not easy. Again, you can't just pull a machine out of the closet, slap it on somebody and say, I'm doing multimodality monitoring. You really need to do it in a systematic way. And this is the thing that I try to advocate for as much as I can. One is to just figure out what you have. You'll find that there are dusty devices in your closet. And those are the fun ones because no one's using them. So you actually get to pull them out and figure out how they work and then use them. But the second, probably the most important, is multidisciplinary buy-in. So you need your neurocritical care folks and your neurosurgery folks to work together, or your EEG and epilepsy folks, depending on what you're using, to work together to have buy-in. This is what we're doing. We're all on the same page. This is who we're doing it in, and this is the type of patient that we're dealing with. And that sort of systemization also makes it easier to infer pathophysiology. So in other words, if you're doing the same thing every time for the same patients, you get an intimate feel for what that physiology looks like, depending on the level of injury, say in TBI. But you can't do that unless you're doing it on everybody the same way every time. So that becomes really important. And everyone, of course, has to agree on the approach. If you want to use a strip electrode in the OR, you got to make sure your operative neurosurgeons are doing that when you do a decompressive hemicraniectomy. If you're going to do a bolt, are you doing it at bedside or in the OR? You got to figure that out, right? And that way, you guys as residents, how many of you guys are residents? Raise your hand. Wow, that way you guys are residents at 2 a.m. when you get the call, don't have to think. I don't want you to have to just need to go and say, well, they fit that criteria. This is what we do. I know there's a system, right? That's the idea. And then you have to be able to connect all this stuff up. Remember, integration is a big piece of this. So you have to be able to figure out how to take all that stuff you just put in someone's head or that stuff you connected to someone's skull and scalp and put it into some system that allows you to actually use it. And then you have to know how to measure it and what those measurements mean and what the limitations are. And that can be challenging because we don't all have that experience. You have to learn it. You have to understand it. That's the point of doing 2 days of this, is you get to see all that kind of messiness. So let's talk about connecting and measuring this stuff. If this is our patient, we have a lot of monitors, and this probably looks like a patient you may have in your ICU. This person has all kinds of stuff, 3 different ICPs, a cardiac index monitor, Lycox, jugular venous oxygenation. You can see how old this is, since most of us don't do this anymore, even though it's in the Brain Trauma Foundation guidelines. And there's even like ventilatory parameters, right? All this stuff has to go together. But if you walk in a room, that's what you got to put together. And the question is, how do you do that? This is how we did this for years and years and years, right? Beginning in the 60s when EVD was put in, this is still kind of how you did it. You had to put together your blood pressure, your ICP, and whatever ventilatory parameters you got. And part of the issue with doing all that and trying to put it together is there's not really good standards on the back end. So our, labels on the GE monitor that you have for heart rate or arterial blood pressure, they mean something. The IEEE has defined what that means, your sampling frequency, your amplitudes, how those are done, how they're quality controlled essentially. And that occurs across things like radiology and lab studies too. All this stuff is very, very standardized, but when it comes to the data we're talking about, including PBTO2 or neuropupillary indices, there's 31 of the 73 terms that we actually had looked at that we use in neuromonitoring were completely missing. And there's no communication standards for any of these devices. So some devices are very good about sending out the data to other systems and some are not. There's not a lot of options to actually aggregate this stuff. There's some open source stuff, there's homegrown stuff, there's research stuff, and there's a couple of FDA approved things, but there's not a lot. And again, interoperability, what kind of physiologic data you're using versus I'm using are not standardized either. And then how do you deal with, the time resolution? There's no standardization of what's appropriate for that. This is what most of us see probably, which is a big flow sheet with hourly data. When did that ICP of 19 actually occur in that hour? Did it happen right after a bolus of hypertonic saline or right before it? That's really important, right? Because either it worked or it didn't do anything. Same with all of these other parameters, whether it's blood flow or PBTO2 or microdialysis. There's a lot of context there that you miss when you only sample once an hour, or I should say endorse a value once an hour. And so, the other thing that you end up missing is the metadata that informs all that stuff. So you can talk about ICP and you're talking about a mean number and a 10-second window of a waveform that's very complicated and it has very little context. So if I tell you I'm measuring an ICP in a patient, let me ask you a question. How am I putting the ICP monitor in? Do you know? What kind of monitor am I using? Am I using a Camino? Am I using a Rametic? How much am I sampling this stuff? Am I just relying on the bedside nurse to document an hourly ICP? Where am I putting it? So right frontal, left frontal? Am I putting it in the parietal lobe for some odd reason? Am I using an EVD or am I using a parenchymal monitor? And you have, I would assume, no answers to this question because I haven't told you. And so all of this data, you really have to know to make any heads or tails. You have to know where the probe is. Is it sitting in a big hematoma? That's going to limit what you're able to say, intuit, or use to guide therapy, right? And things like, is the patient decompressed, make a big difference. If I have an ICP of 20 and someone who's not decompressed, I'm feeling okay, let's keep an eye on things maybe, but an ICP of 20 and someone's decompressed, that's a real problem. So all of this data, you tend to know at bedside, but especially if you're looking at this stuff after the fact, you have no idea. And even when you're at bedside, you have to use that to interpret things. So knowing all that's really important. This is the data aggregation system we use. And again, everyone's different. So I'm just showing you what we use to highlight the complexity, but also the ability to actually be able to integrate this stuff. So we use Rametic where I'm at, which is an ICP, PBTO2, and temperature monitor. We do use electrocorticography or electrodes placed in the skull. We use cerebral blood flow, microdialysis, pupillometry. All this stuff gets fed into one system. In this case, we happen to use the CNS, which is made by Natus as an engine. I do have some conflict of interest there, but this is, again, what we use locally. That's why I'm showing it. And you can see there's a lot that has to aggregate. But it becomes really important for the utility of monitoring, which we also asked about. If you get all this data, we ask all these experts in this consensus process, what do you need to be able to do to use it? I can't, I'm assuming, just go to the bedside and look at a single number on the monitor, right? And as it turns out, no, you really can't. So everyone agreed, there was consensus that you do need a bedside display, but you need it of the live measurements, both single and multiple, and they need to be aligned over time. So you can see what's happening in one when another changes. But you also need some summary data. That would be helpful. Some kind of way to say our ICP has been elevated 20% of the time this last 12 hours, this last 24 hours. Your nursing staff can sign that out, for instance. That's really important. Having access to some high frequency data is going to get over that barrier of just having hourly data, not knowing quite what to do with it. And so the highest resolution you can get, even minute to minute, is really, really useful to see things like these instantaneous ICP spikes that are here. And the folks at Maryland Shock Trauma have shown do have some bearing and outcome. You need to be able to annotate stuff. ideally. And whether you're using a research-only tool like ICM Plus or an FDA-approved tool like CNS, they both have this annotation function, which is really, really useful when you're dealing with this complex high-resolution data. But even if this is bedside in Epic or something, or whatever your EMR is, which I have to assume is Epic because I'm in Wisconsin, you have to be able to annotate stuff. And then I think, and there was actually consensus on this, that remote review is actually critically important, because I can't stand at the bedside and watch this stuff. I need to be able to sit back and look at this at 2 p.m. in the office and talk to the teams that are in the OR helping take care of these folks and the team in the ICU and put all this stuff together and look at it and go back and forth and zoom in and zoom out and do all these things. So that actually ends up being incredibly useful, to be able to manipulate this data, to look at it by standing back, having the context in mind, but having this bird's eye view as well. In terms of annotations, I'll show you why these are important. We actually look back at our patients and try to figure out, well, how many times are we actually annotating this stuff, giving a clinical context? And our nurses, believe it or not, annotated things 111 times per patient on average, for more than 16,000 annotations. That's a lot. So, and you can see this list of stuff here, right? And it's all kinds of things. If you can read it, you can see there's all kinds of stuff, like they were turned, they got intracranial, or they got, hypertonic saline, they got pressors started. And these can be very simple. They don't have to be complicated annotations. We have it set up. You'll see this in the workshop, where you just hit a button and say, okay, and that's it. For things like I bolused sedation. Half of these were unique though. So the nurses were typing in stuff just because it happened to be a different context than a standard button. But take, for example, this increase in brain tissue oxygen that you can see here. So this is an hour of multimodality monitoring data. You'll see this a lot in the workshop, and I'll acclimate you to it. But here there's an increase in PbTO2. And here's my question. Is it because the CPP is going up and the ICP is going down, or is it something else? And as it turns out, there's an annotation there, which is really helpful. And what it says is, Bonema, one of our neurocritical care faculty, just increased the FiO2 to 100%. So actually, I can drive up the CPP, which helps my ICP. That's great, but that ain't the reason I fixed or improved the brain tissue hypoxia. So I need to look somewhere else. That annotation is really, really critical. Context is super important. And then how do you, as the bedside clinician, actually interpret this stuff? And that ends up being sort of the tip of the spear for doing this. You really have to be able to use it clinically. That requires some, thought. So I'll give you an example of, this happened to be a patient who underwent a decompression. They're post-trauma day 3. We're battling all of these different secondary brain injuries. And the vitals at, 2 a.m. look like this. The ICP is elevated, but so is the mean arterial blood pressure. So is the heart rate a little bit. And so you get the call and you say, you know what, I think if I reduce the mean arterial pressure, I'll probably reduce the ICP. So why don't we just give a dose of labetalol? And, it's 2 a.m., you're thinking reflexively, and that's totally fine. Maybe that's something you do. Maybe that's something you're cringing at right now, which is okay, because I always do when someone gives labetalol in the acute period, unless they absolutely need it. But in any case, the nurse calls back and says, hey, the IV labetalol seemed to work. Heart rate came down here in the red. Blood pressure came down, as you can see here in the orange, and our ICP did okay. It's starting to trickle down, but you got some better control of that map. But here's the problem: you're looking at something very, very close up when you look at those numbers, and you can see this wheat field in front of you. But when you step back and actually look at things in a bigger context, you actually see what's going on. And so here's the bigger context. If you look at these other monitoring modalities, here's our cerebral perfusion pressure, which just hit the toilet. Here's our brain tissue oxygen, which actually declined. Here's my blood flow, which you can see dropped pretty dramatically into the ischemic range. And even my EEG, as displayed by this % of theta, or fast frequency activity, relatively speaking, drops. So we actually cause harm with this labetalol. This was not a benign intervention to treat a MAP. This was a very non-benign or malignant intervention that actually created transient ischemia. And if you don't believe me on the EEG, here's the waveforms if you love squiggly lines like I do. But they really flatten out and attenuate. And that's indicative of ischemia as well. So being able to interpret this stuff, you really have to be able to step back and look at it and then communicate it ultimately. And that is sort of this interesting thing that we're trying to standardize or develop, because it seems to be really, really useful. And why is it useful? I mean, if you're the bedside clinician, you're thinking, well, I'm looking at it, I'm interpreting it, let's make a decision. And that's fine. What we found, though, in this Delphi consensus process is that everyone agreed, there was consensus that sitting back and looking at the, the cornfield with the crop circles, right, is really independent of going to the bedside and making decisions on everything from whether the foliage should be removed to whether you should treat temperature. And the reason for that is as an intensivist, I don't have the time to do that. I just don't. I can't sit back, stare at this data and look at it and make inferences, try to communicate that, make decisions. I need the information, I need it interpreted, and then I need to make decisions. I don't have time to sit back and stare at this stuff just like we've done in this talk even. A lot of us don't have the technology during bedside care, so I might not be able to look at everything in a beautiful aggregated display. And a lot of us, as general intensivists, may not have the knowledge of these devices. That's okay. Why would you have the knowledge of a device that's used by less than 5% of centers, right? And so all of those end up being barriers to you just kind of saddling up, looking at this data and deciding on what the clinical course of care is based on the last 12 hours, 24 hours of data. And that's okay. You just have to acknowledge that's the case. And if you're interpreting this stuff, it ends up being really fun because you get to zoom in, zoom out, as you mentioned, look at these displays in different ways, different relationships, different time scales. And this employs all of the cool things you learned in medical school and that you're learning in residency about cortical physiology, which is really fun. So there's all of this stuff that you get to put together that you're seeing that really, in many cases, no one's really described all that well. But we have to report it. And so the framework we put together is basically, the first thing for any modality, it's validation. Is it real? Is this a real PBTO2? Because if it's not, I need to tell you so you don't rush in there and give hemoglobin and put in an EBD for a low PBTO2 a la boost. I need to be able to summarize this stuff so you know where we're going. The PBTO2 has dropped, and now 50% of the time that PBTO2 is low relative to the day prior where it's 10% of the time. That's a problem. That summary is really important. Defining events. So when I gave hypertonic saline, this last 3 times, the average ICP response was 7 millimeters of mercury drop. That patient's responsive versus someone who there was no change in ICP, right? So defining those events and correlating with other stuff. When my ICP went up to 25, the PBTO2 consistently became hypoxic. Well, that's a patient you need to get aggressive with as opposed to someone where maybe the CPP, the PBTO2, and everything else is actually okay. In which case, maybe we can try to temper the management and do other things that are less aggressive than putting him on pentobarb pump. So it really is helpful to kind of have a framework to think about any one of these given things, although it seems overwhelming, just taking them one at a time actually can give you a lot of insight. But you do need that expertise. And what I would argue is most of you have expertise in cerebral physiology and how the brain interacts with things like the lungs or the heart. You just got the evidence base. Congratulations, you're all experts there. Critical care, most of us have gotten that experience and you're dealing with your post-op patients. You know a lot of critical care. Device mechanics, technical expertise. These are things we're going to talk about in the next 2 days. So you'll get that too. And then things like how do you do autoregulation indices? How do you deal with basic EEG stuff, right? Those are all things that you can kind of add to sweeten the pot. But these are the things that everyone agreed upon were useful topics or areas of expertise to have if you are going to step back and try to interpret this stuff independently and work with the team to make management decisions. There's 2 studies that have actually looked at this. So if you were to report this data, if you were to sit back, look at it, make inferences, and then tell the clinical team, hey, here's what I'm saying. Your autoregulation is getting worse. Your CPP is a little on the low side, and your optimum CPP is actually closer to 75. The clinical team can take that and make a decision. And then after that decision is made, it's important to look back and say, okay, now that you made that decision, what changed? Is it changing in a positive direction or negative direction? It's just hypothesis generation. That's all it is. This is science at the bedside and of one clinical trial, right? So it's really, really useful to do that. And the first study that came out was actually a pediatric ICU study where they looked at patients with pediatric TBI before they started doing this and reporting things and working with the team. And the way it worked is, they would take all this multimodality monitoring data. In their case, a lot of it was invasive, but there was some non-invasive stuff. They talked to the team. They looked at stuff remotely, reported it to the team. The team made a decision to adjust care, and then they went back and looked at it again. And when they did that, there was, some benefit. This wasn't super powered to look at a lot of things, but they did have less mechanical ventilation days. less days on monitor, which is surprising, right? You'd think if you were using this stuff, you'd keep the ICP monitor in for a long time. But in fact, they were able to de-escalate and say, hey, everything looks good, get that thing out. And that's really important, actually, and useful. And we're at the same time doing the same thing. We've been doing a reporting sort of platform with all of our TBI patients. That was our use case, right? Standardized, every TBI patient, if you met criteria, got a Bolt and invasive comprehensive monitoring and reporting. So it comes with me putting a document in the medical record, us sitting down at 2 p.m. to reflect on what's happening in that morning and set goals for the evening. And we looked at our patients before and after we started doing that. And, we noticed a couple of things. So one is we just wanted to talk about what are we actually reporting. And this, you can tell I love Circos plots. There's 2 in this talk alone. But you can see all of the stuff that was interrelated. These are things that were reported as being correlated. And it's overwhelming. I'm not going to walk through it, but it just indicates that there's a tremendous amount of correlation that's potentially clinically relevant in any one of these given 24-hour periods of monitoring. But when we looked at what that did, we actually administered fewer hyperosmotic agents. We had fewer days of anesthesia because, again, we could get things off patients that might be harming them. We had less time spent with an elevated ICP above threshold. And this is where I was actually really surprised. But when we controlled for injury severity and age and gender or sex, we found that we actually had better outcome at 3 to 6 months using just a 5-point ordinal GOS score. Granted, it's fairly crude, but there was some difference there. And I wasn't totally convinced, but when I looked at it over time using a statistical process control chart, this was before we started reporting in terms of the number, a proportion of patients with poor outcome. And this is after we started doing that. I mean, it was fairly clear. So I think by doing this, essentially you can imagine communication is going to improve patient outcome, right? And that's really all we're doing. But we're communicating something that's really complex. Nonetheless, it's complex in a way that I think all of you guys have an intuitive sense in terms of what's useful and what to do based on what you are seeing and what you are interpreting. And that's where acting becomes really important. Focus on those actionable parameters, right? There is some super interesting physiology that you'll see if you're doing this, regardless of what you're monitoring. But not all of it's actionable. Focusing on that stuff like our ICP thresholds and what that's doing to CPP or autoregulation, that's an actionable parameter. Focus in on that stuff, make a hypothesis, test it, and then once you know what's working, what's not working for that particular patient, you can set your goals going into a night shift or going into the next day. You can deal with those actionable goals in a couple of different ways. The simplest way to do this, and I advocate for looping in the bedside nursing staff in not only educating them on what you're monitoring, why you're monitoring it, give them something that says, here's your thresholds, because now they can look and do a very essential interpretation that allows them to call it up to you. And, they might say your PBTO2 is less than 20. And now you get to go and actually figure out why. Is it the low CPP? Is it a high ICP? Is it the cerebral blood flows? Or whatever the case may be. So simple thresholds are okay to start, but they're not the only thing, as you guys probably are keenly aware, right? One single number as a threshold is fairly useless across the board. You really need multiple parameters, and that allows you to go in and actually figure this out. And then you can start applying these different things that are out there in the literature, like Boost, where you say, okay, well, I've got this parameter and I've got this related parameter. Can I fit them into some kind of heuristic or protocol? And that's where the CBIT guidelines can be helpful. Those just sort of recapitulated and refined the Boost protocol, which kind of simply puts people in 4 buckets. Either your ICP and brain tissue oxygen is normal, one of the 2 is abnormal, or they're both abnormal. And based on that tier, now you got some options, right? And they're not the same options. And each one of the options is a little bit different. Why? Because it's actually addressing a different underlying pathophysiology. And that's the fun part. If you have some way to look at different aspects of brain physiology beyond just ICP and PBTO2, you can even refine this more. Other algorithms are coming out, right? There's microdialysis-based algorithms that have been proposed. I wouldn't say validated. There's algorithms to try to treat spreading depolarizations, which are currently under a clinical trial, a phase 2 clinical trial, where we see the pathology and we randomize and either take them through a tier-based treatment a la Boost, right? to normalize physiology, to super normalize physiology based on things that we know sort of exacerbate the presence of spreading depolarizations, which if you come to the workshop, you'll learn all about because I love them as a phenomenon. Or starting ketamine, which you don't routinely do, but in this trial, if you're continuing to have spreading depolarizations, despite optimizing the physiology, you're actually starting a medication that we know works, but has real risk. And ultimately, all this stuff should just fit in your head as a heuristic. As you get sort of more and more comfortable with the expertise that you have, you sort of put this in the context of the underlying physiology. So you've got the numbers in your head. Now you can kind of decide, is this a problem with pressure and why? Is it CSF? Is it hyperemia? Is it a mass lesion that's actually worsening? You can put in the context of your metabolic supply and demand. That patient's serum glucose is 80. Maybe that's part of the issue that I'm dealing with. Or increased metabolic demand. Is that patient seizing? You've got an EEG on, let's use it, right? So those simple heuristics take all that very complex data, and even if you're just at bedside and trying to get a sense for what's happening now, you can put a lot of what you know into to work to be able to decide what you think the problem is and make those decisions that you think will probably impact them positively. And this has been advocated by none other than folks like Randall Chestnut, who did the Best Trip trial, which actually generated a lot of controversy about ICP monitoring in general. And what his take is that intracranial pressure monitoring, it's a tool, it's a biomarker, if you will, of a variety of pathophysiologies. So you can't rely on the one number. You shouldn't rely on the one number to inform treatment decisions. It's really situational awareness, so to speak, or informing this kind of larger heuristic of treating your patient. So I'll end with, and I think I've got a few minutes to do this, just a quick case to highlight what I'm talking about in terms of the complexity of all this stuff, but also the utility of it potentially. This was a young patient who had an initial secondary brain injury after trauma with hypoxia due to a poor intubation in the field. So she's already very, very sick. She has post-resuscitation GCS of 6T, and she's got a lot of other injuries. So she ended up getting a bolt in the right frontal region with all of our different monitors. She gets an EVD as well. And as you can see, she's got this very large evolving contusion on the left side. This is a very, very devastating traumatic brain injury. We're hoping to try to get her through this. And if you zoom in to an hour of data, just to acclimate you, the red is heart rate, the orange is mean arterial pressure. You've got intracranial pressure in green, CPP in blue, brain tissue oxygen in orange, blood flow in purple, end-tidal CO2, brain temperature, oxygen sats, and PRX, which is a number that represents autoregulatory function or dysfunction. The higher, the worse, just to simplify. And what I'll highlight first is just that you've got this intracranial pressure elevation, right? Very easy to see. The ICP goes up for 15 minutes as high as 35. Well, what's the reason for that? Why? Why is that ICP going up? Is it spontaneous? What's the timing of that elevation in relation to your arterial blood pressure, in relation to your CO2? What do you think is the cause? So based on, in this particular case, there's a dramatic increase in heart rate and in blood pressure and in blood flow. So what happened? The patient was stimulated, right? That's probably their neurological exam when you go to bedside, or patient's been moved, turned, or bathed. And so, that gives you a sense for what that patient maybe needs, maybe more analogous sedation, maybe less frequent neurological exams. Now, if you zoom out to 24 hours, this is a huge chunk of recording, and I actually do this, right? Because it's useful to see different time scales. You can see our elevation in ICP there in the red box, so it's a lot smaller. But now there's a dilemma. If you look at the area in the gray box, the CBF, or the cerebral blood flow, is actually trending above 45 mils per 100 grams per minute in absolute blood flow, which is probably too much. For an injured brain, that's a lot of blood flow. That's suggestive of hyperemia. And if you look at the PRX down below, that's also abnormal. It's abnormally high, suggesting there's also not autoregulation. So if there's no autoregulation, the vessels are just kind of passively dilated, and you have just blood rushing them like a fire hose. So is this why the ICP is climbing every time you have a stimulation event? Right? You can see these big spikes. And on top of that, there's also brain tissue hypoxia, which you can see in this orange line, which is below the threshold of 20 underneath the dashed line. So here's the question. Is the CPP actually running too low, and therefore our brain tissue oxygen is low? and we're vasodilated and our blood flow is higher as a result? Or is the CPP actually too high for that guy? And paradoxically, the CBF is driving past the upper limits of autoregulation. And I don't know. So we have to test our hypothesis, right? So we start pressors here in the red line, or in the red arrow that you can see there. What happens to the blood pressure? What happens to the CPP? Well, they go up like they're supposed to, which is good. But what happens to the PbTO2 and the CBF, right? Well, the PbTO2 actually goes up, but the CBF gets worse, right? So we've made some improvements. We're getting blood flow and we're getting interstitial oxygen delivery. However, our CBF is actually becoming worse or more hyperemic. And the the PRX is actually going down because our CPP is okay. So we fixed most problems, but our CBF is still a problem. So, what can you do? Well, in this case, we actually started driving down the CO2, not to dangerous levels, but nonetheless, we were able to drive that down, which actually drove our blood flow down, perhaps even too much. But that reduced our CBV, reduced our ICP substantially, which hadn't responded to the CPP. So we got two different targets that we had to establish, right? One is the CPP to enhance brain tissue oxygen, but we also had to give some vessel tone in order to overcome the autoregulation and drive down the ICP. Now we zoomed out even further. Now we're talking about 2 days. Here's that gray box we were just looking at for reference. And you can see how our CPP is persistently higher. The PbTO2 is finally improving to where it's resolving the brain tissue hypoxia is resolved. And now that the brain has that substrate, finally, it's got oxygen, it does the only thing it can do in its injured state, which is to seize. And unfortunately, those seizures were very, very focal because of the degree of brain injury. You could see them on the depth electrode down here at the bottom in a single spot in the cortex, but the scalp EEG didn't really show these seizures. So we would have missed them, but we had ECOG. And the reason those seizures occur is now the brain's got enough substrate to do it. It just doesn't do anything else, unfortunately. And that creates increased demand. It outstrips supply. And this number here in black is actually the brain water content measured serially over time. And you can see there's a massive jump in the brain water content. So the neurons are stressed, they become edematous. And at the same time, there's a pupillary asymmetry. And finally, as that herniation kind of matures and evolves, there's a drop in blood flow that becomes durable. This patient ended up not doing well as a result of that combination of different pathophysiologies. So just to sum it, and we're right at 45 minutes, but neuromonitoring, we've defined it. It's access to measurements, detecting secondary brain injury, and using it. You have to integrate this stuff, including systemic physiology, and communicating is really critical. And if there's anything you learn in the 2-day workshop or even just in this hour, it's that using this stuff, communicating it, and individualizing your care is the key to using it. And you can do it now with what you've already got. And I advocate for you doing that as best you can in a systematic way. So with that, I'll stop and say thank you. Take any questions if I have. Not formally. I think what we use is one of the few, if not the only, FDA-approved ones here in the U.S., and that's the CNS Moberg, which used to be from the Moberg Solutions Company, now it's from Natus. Whether that's the best or not, whether that's the only way or not, over time, I'm not entirely sure. A lot of folks use ICM Plus, which is out of Cambridge. It's been very well established. However, in the US, it has not been FDA approved for clinical care. So really the only option for most folks is that CNS monitor. Again, not an endorsement per se. Yes.
Really enjoyed the talk. Thanks. It sounds like what you're describing is almost a dedicated individual supervising the multimodality. Almost like an epileptologist.
Have you heard my talks about that?
Is that something you guys are working toward? Is that idea that there's going to be some sort of multimodal neuro monitoring clinician whose dedicated job is to basically that?
Yeah, it's a good question. On the Teams or on the WebEx, rather, if you didn't hear it, the question was, it sounds like there's sort of this idea, perhaps a single physician who is almost like an epileptologist interpreting this stuff separately. And is that something that you envision putting in place potentially? Is that to kind of summarize it? Short answer is yes. And that's actually what I do. I started providing that as a service essentially, and that's my job when I'm not attending the ICU. We've trained up a new faculty that's just joined us as well to kind of rotate with me so I get some sleep and have vacations. But that is, I train in clinical neurophysiology. I'm an epilepsy person as well. And that was my model. And I think that's actually been really useful doing it that way because of those limitations we just mentioned. But it is a lot of lifting, and it's doesn't have a compensation structure as yet, and that's one of the big barriers to doing this. Yes.
My question is how long are they to actually build?
You guys are getting right to the questions here. The question was how long are we, or how far away are we from potentially being able to bill for something like this? It's a good question. There's a lot changing right now. I was actually just talking about this with one of my colleagues who was part of the AAN advocacy group in DC, because that is sort of the big question. I've advocated for it before, but there's been a lack of data. I think now we have a larger consensus. And so the plan is to try to take that back to get some lobbying underway. But who lobbies, how they lobby, and whether there's going to even be physician representation on the CMS CPT committees is probably not something that's going to be the case anymore. And so time is kind of the essence at this point. Otherwise, we're kind of stuck with using, critical care codes and having to be there at bedside, as opposed to the remote reading we do for, say, continuous EG monitoring.
Thank you.
My pleasure. Thank you, guys.
Great.
Hope so. Oh, I got one more question in the back, and the rest of you guys, of course, if you need to head somewhere else, feel free. Yes, sir.
How you would lead to have a standard for monitoring guidelines, accuracy, get it on those monitoring measures.
So in terms of here, state that one more time. Sorry, I was having trouble hearing you.
Like you said, that we're distinct standards for neuromonitoring.
Yeah.
It all to implement those.
Yeah. So the question for the online folks is: there's all these potential different standards. Would it be helpful to harmonize them? Yeah, it would be. I don't think you can truly harmonize things because not everyone's going to have the same equipment. But if you can harmonize conceptually, this is a monitor that's capturing a similar data point to this one, and more importantly, harmonizing what you're calling PPTO2 and what I'm calling PPTO2, and knowing what that metadata is. Those are, I think, going to be the key things. And part of what we'll talk about in the workshop are some of the limitations of even labeling stuff. You might label on your bedside monitor the ICP as IC1, and I label it as ICP. How do you put those together if I did want to look at that data, retrospectively, or do some kind of a study, right? So that also is part of harmonization ultimately, is using this collaboratively. Were there any questions on WebEx, by the way? Okay. All right. Well, thank you guys. We'll talk a lot more. Hope you can join parts, if not whole, of the workshop. See you guys shortly.